FAVMI presents Unfolding Mental Illness, hosted by Saraswati Suresh.
Hello, everyone. Unfolding Mental Illness, presented by FAVMI, presents its 18th episode. We are also the regional zone of Families Alliance on Mental Illness, FACEME India, founded by Dr. Nirmala Srinivasan. Through these episodes, we hope to empower families with insights from experts, lived experience, and bring more awareness in the space of mental illness. I am Saraswati Suresh, the host for today, and I'm joined by my co-host, Dr. Sachin Ganorkar, who is the founder, member, and director of FAFMI. Our topic for today is mood disorders and family carers. Across the world, there are millions of people who are facing this challenge on mood disorders, and we aim to, through this discussion with our guest today, we aim to bring about understanding what is mood disorders and offer strategies for resilience and understanding them by family carers who are the main support for the path of recovery to the individual. Our guest for tonight is Dr. Milan Balakrishnan. Dr. Milan Balakrishnan has been a guiding force to my family for the last few years, and has immense experience of more than 15 years in the field of mental health. He is a consulting psychiatrist and head of the department in Masina Hospital Mumbai, and also a consulting psychiatrist at Bombay Hospital Mumbai. He's also the trustee of the NGO Bipolar India and has been the ex-secretary of the Indian Psychiatric Society of India. Thank you, Dr. Milan, for agreeing to do this podcast with us, and a heartfelt gratitude for it.
Thank you. Thank you for having me.
Yeah. So let's start on with this conversation in understanding is what is mood disorders, and how different is it from mood fluctuations or mood swings, which is which we talk, we all of us talk about it. And how do we one then identify, saying that, oh, these are some warning signals and we need to seek help primarily?
Right. So if we overall look at mood disorders, they are one of the most common mental health issues in all over the world. So we're looking at almost, say, 5 to 8% or almost about 10% of the population worldwide is dealing with a mood disorder at some point in time in their lives. Now, when we look at mood disorders broadly, we would be talking about major depressive disorder, and we would be talking about the other mood-related disorders like bipolar disorder and related disorders. When we look at how do we differentiate them from usual mood changes, right? So typically, normal mood changes would be you start off in the morning, you're in a good mood. You have an argument in office, so you get screamed at on by a boss. You feel upset, angry for a while, or unhappy for a while. You sort of process that. You keep figuring out what went wrong. Then you meet a friend again, you have a discussion, you bitch about how the bosses all over are the same, and you move on, right? Those would be normal mood changes that we all experience. We all feel sad, we all feel angry, we all feel happy through the day, and it's dynamic in the sense that it keeps changing between all of these moods through the day. Now, mood disorder is different in the sense that uh, this sadness that you feel temporarily becomes more prolonged. It is more intense. It is continuous in the sense that I feel sad, and even when I meet a friend and we're having a great conversation, I'm still not feeling better. My mood is not changing. I'm just doing it for the sake of doing it, but yet I still continue to feel the same in terms of mood. So when this mood, whether it's sadness or whether it's high energy states, are more continuous, then we would look at them as possible mood disorders, which need to be evaluated and which need to be managed as may be required.
So when you say prolonged time duration, is there a specific
Yeah, correct. So usually for depression, it would be at least a period of 7 days or more continuously. For other mood disorders like high energy states, it may be again between 4 to 7 days at end. The point being that the regular changes of mood that happen through the day are no longer seen, and these moods stay more consistent and pervasive, and they are more distressing than your usual mood changes.
so it basically harms the working condition of the person?
Correct. Which when it starts affecting day-to-day functioning, okay, if it starts affecting day-to-day functioning, day-to-day interaction, and affecting occupationally also, where person is not able to perform effectively, not study, or not able to uh, get their work done, then we would think that it is a problem.
Okay. So what are the major causes of mood disorder? I mean, is it primarily linked to mental illness, or substance abuse, or is it related to genetics or hormonal changes or
Hmm.
lifestyle? What is the main cause of it?
Right. So one mood disorders are uh, caused by a variety of causes, including causes which may be multifactorial, which by which I mean that there may be a genetic risk, which means that if there is if a parent uh, has had a history of depression, the chances of the child having depression or bipolar disorder is higher than that in the rest of the population, which means that genetically, certain genes that make you prone to these illnesses are triggered more easily in these brains, right? Which leads to chemical changes in the brains, and these chemical changes then lead to these mood changes, which are their outward manifestation. So the inward changes are chemical, but the outward manifestations are, of course, in terms of behavior, mood, and how they feel. This can also be contributed to by other issues like endocrine issues. So where we look at thyroid levels, cortisol levels, vitamin B12 and D3 levels, all of which can contribute to the problem. So these may add to the problem and make them worse. We also find that mood disorders, the vulnerability is higher in certain states, states as in terms of, for example, women. We find mood disorders are more common uh, premenstrually, uh, peripartum, during pregnancy, just prior to pregnancy, or meaning early pregnancy, and also postpartum. So these are and perimenopausal age groups. So both perimenopausal and postmenopausal age groups would be vulnerable to these mood changes. Again, reason being that these are times where hormonal changes take place quickly, and these hormonal changes also have an impact on the same brain chemicals that we are talking about. So basically, multiple factors leading to these chemical changes can cause depressive states. So along with all of this, even chronic stressful situations that last for long periods of time, difficulty with coping for long periods of time, could also, over a period of time, lead to the same brain changes in the brain. So, we are looking at the brain changes are the are the final end product, but there may be all these various factors that could lead to these brain changes.
So basically, it could be any of these combinations which would,
Correct. It
yeah.
could be all of them put together. It could be one at a time. But like I said, there's a certain genetic vulnerability where people are more at risk. So, which is to say that, for example, some people put under the same kind of stress for many years may still not develop a mood disorder, while some people who with milder stress levels also may develop a mood disorder. So there isn't like a threshold to say that X amount of stress is enough to cause a depressive disorder.
Okay. It's the way the person handles the situation or the coping mechanism.
Person handles and where the way how vulnerable is the brain to that impact is also the question. It may be how the person handles it as well as how the brain is able to deal with it.
Okay. So what are the treatment mechanisms for them, both in terms of medications and therapy?
Correct. So for example, depression, usually, like I said, the end product is these chemical changes. So most treatments revolve around correcting these chemical changes, which essentially means that we have medications like which change the serotonin levels, serotonin dopamine levels, serotonin norepinephrine levels in the brain and improve mood, make mood stable again, bring things back on track again. So those are medications that are available to correct the mood change. But when we are looking at patients who are prone to, for example, chronic stress and get into these loops again and again, then we also need to say that okay, medication will help change the sort of last step. But are we dealing with the top down things? So are we dealing with what is leading to those chemical changes? So the genetic factors obviously we can't change, but stress related factors, ability to cope, certainly can be worked on through psychotherapy, where we usually work on improving coping skills, improving problem solving mechanisms, increasing resilience, increasing the ability to deal with stressful situations. So a combination of all of those put together would finally help us sort of get better. When we talk about the other group of mood disorders, which is like the bipolar disorder category, we would look at a slightly different group of medications, which we would call mood stabilizers, which help patients stay stable without going through these ups and downs of mood that happen in bipolar disorders as much. So there, the group of the treatment modalities may be slightly different, but yet therapy may be a support in order to deal with the stressors of the illness itself. For example, a lot of people not knowing what the illness is, how to manage it, the impact that the illness has on them, and then eventually on family, and then how the family impacts the individual also becomes a bit of a chain reaction because one depression comes with a lot of irritability, a lot of feeling upset, unhappy, and then that sort of can trigger off things for other people in the family. And not knowing how to, not understanding the illness, as well as not knowing how to handle someone with a mood disorder may trigger more problems for both, for the caregiver as well as for the primary patient.
Yeah. So how does the individual then build resilience? First of all, understanding that, yes, I have facing a situation and then actually building uh, coping mechanisms.
Right. So, like you said, the first step is, of course, understanding fully that I have a disorder. I may not have full control over my disorder. My disorder may come and go. It may create problems for me. It may lead me to feel a certain way. It may also lead me to not function as effectively as I usually function. So being aware of all these things is certainly sort of the first step in dealing with the disorder, but also sort of working on identifying sort of usually what is helpful is identifying early signs of the illness, for example, since most of these illnesses are episodic and will come back at some point in time again. Being able to pick up the early changes, which may be minor things like sleep disturbance, increase in irritability, um, feeling more upset than usual, not enjoying things that you used to enjoy before. Picking up these early signs is important to sort of help identify when the illness is coming back and when we need to deal with it. And early in the course of the illness itself, one, reinstitute treatment, two, also start working on other simple things like um, increasing physical activity as much as possible. So it may be just a walk, a sport, or doing something that the person enjoys for a short period of time. If he finds that it's very hard to push, it may be okay to not try it immediately as well.
Hmm.
So it may be okay to say, wait for a while, let me start feeling a little better and then start doing it. So knowing your abilities, your limitations, your strengths is certainly going to help. In terms of building resilience, for example, it's important to also be able to identify that when I find changes in mood, what are the things that I can avoid. So, for example, I know that I feel irritable. So maybe around that time, I want to step back from people who get triggered by me and whom I may trigger. So doing these sort of small, simpler things may be very helpful in as a part of not letting the illness escalate very quickly.
Okay. So, basic observations and, keeping a track of them is,
Correct.
is to start would be the best mechanism.
Which would be very useful, and that is also the responsibility also of the caregiver as well as the patient to sort of work together to identify these things and discuss it. Because also what tends to happen is for a person with mental illness, caregivers sometimes become hyper vigilant, which is like every change is then held on to, and see, you are doing that again, maybe your illness is starting off again. So that can also be very distressing for people with mental illness. They may not be able to sort of understand why everything that I do is then labeled as illness. So I think that's something that's important for caregivers to be very vigilant, and also caregivers also need to work a lot on their own education in terms of the not only knowing symptoms but also knowing what are the symptoms that are common in my particular family member, right? Or what are the first few symptoms that I see in my particular family member. So knowing that is very important. Not just knowing symptoms. Knowing symptoms is a general list that we are looking at, right? But being able to identify that, okay, this is what changes in him or her before this escalates is something very important. Again, to avoid just jumping onto every symptom. So if there is doubts, questions, it's fair to ask the therapist or the psychiatrist as to, are these symptoms of the illness? Do you think that the illness is starting off? Rather than getting into this sort of blame game with the patient is very important, because that can be very distressing for the patient, because it's very invalidating for the patient, because he doesn't know what to do then or what not to do in order for the family member to feel comfortable. So I think that again, where I was coming from was that both sit together, look at symptoms as a collective, and see what are the things that we find common, that we know that okay, when this is happening, things are going wrong. Let us identify these things, and let us help sort of identify these things so that we can prevent episodes from escalating very quickly.
Yeah. I think it's just that the families go through so much that they tend to become oversensitive to the entire situation.
Which is true, which also comes from a lot of caregiver burnout, comes from a lot of caregiver distress, caregivers not being able to take care of themselves because of the time and sort of resources that are put into uh,
Okay.
taking care of the patient can have a huge impact on caregivers, right? So which also means that the caregiver needs to ensure that while they're working with the person with mental illness, they also have to take care of themselves.
Yeah, that's so true. Yeah. I'll hand it over to my co-host, Dr. Sachin. Yeah, Sachin, you can take it forward.
Yeah, thank you, Dr. Milan. Thank you, Saraswati. It's been a wonderful
Thanks.
conversation till now. Thanks. So before going to the next question, I think there's one quote from Adele, which she says that she's a famous singer. She says that she had crippling anxiety, but I always kept it hidden. Talking about it doesn't make you weak; it makes you more human. So I think the next question is, as we were discussing, is what are the misconceptions about mood disorders, and how do you handle the stigma around them?
Hmm. Hmm. Like we said, there is uh, two extremes in terms of stigmatization. One is one is not talking about it at all, and the current issue also of tending to label everything as mental illness as well, which is also a form of stigmatization, really. It's just again comes from lack of awareness. It comes from mislabeling. It comes from all of that, right? So that is the other extreme. I think common misconceptions, of course, are that one when we look at mood disorders is that these are very often not recognized because they seem to be extensions of normal behavior, but behavior that becomes more problematic and starts impacting people. Also, since it is unlike other illnesses where only uh, patients struggle, since there's an outwardly behavioral manifestation and since it affects people around you, the impact that it has can be uh, can be sort of circular in the sense that families may respond in aggressive manners, may not know how to deal with it, may blame the patient for not taking care, not doing, working hard enough, not putting enough effort to get out of it. That's one very common myth, right? That it is not an illness. It's a weakness of mind, or it's a problem of personality where the person is not putting enough effort to push himself or herself out of it, which is a fairly common misconception, and that leads to again a lot of stress for the patient because treatment doesn't happen and diagnosis doesn't happen because long time gets spent in all of this. Of course, the other common issues of blaming God, ghosts, all of those things, of course, continue to happen. A lot of time is spent in all sorts of sort of other treatments uh, before before medical help is sought. So that is another common myth. The other issues, of course, being that, for example, a lot of patients with depression or mood disorders will also tend to have comorbid substance use disorders because one, when they don't know how to tackle it, some of them are advised by people to start start drinking or smoking up weed to feel better. And that's fairly commonplace advice that, "Oh, why don't you do this? You might feel better." And that leads to, of course, substance use coming into the picture, and the substance use can worsen the mood disorder. And not only that, it does worsens the mood disorder, it also makes the substance then a point of blame for everything. Although the substance is a factor in the whole mood disorder, but it's sort of mixed into this picture, right? So then it becomes a morality and a substance use issue rather than a mental illness issue. So they said, because you were drinking alcohol, this has happened. Because you did this, this has happened, and that whole blame around that starts to get create more trouble. So these are the various common myths and misconceptions in mood disorders in general, and mental illnesses in general as well. Most of the myths are fairly common for all the mental illnesses.
No, no, thank you, doctor. I think that was a very good explanation. And also the term that I think whatever is seen today in today's world is branded as mental illness when actually it is not. So I think it's very important to be careful so that people who really are struggling should get help. So thank you very much.
Like we said, it's a form of stigmatization, because you're then labeling even non-mental illness as mental illness, and then just creating
Correct.
a sort of story around it without actually understanding mental illness.
Correct. So even if we see normal humans doing evil things, I think that is called as mental illness when actually it is just a normal human who's causing violence, and it is an a person who is mentally ill may not be actually harmful to anybody. So I think
Very
that's a very
true,
good.
which is very true, which is also true from the fact that mental illnesses are less likely to be related to violence than normal people, and mental illnesses are much more likely to lead to self-harm than violence towards others.
Thank you, doctor. To take the next question, what is the future of treatments in mood disorders, and how can digital health and AI help uh, in today's world for looking for diagnosing and treating mental health disorders?
So I think that's a topic that's one very interesting and close to me, about how technology can be integrated and used effectively to reach out to a larger bunch of people, because we're looking at huge populations, right? We are looking at 10% of a 1.5 billion population. So if you're and that we're talking only about India, not the world. So we're looking at massive populations. Uh, Looking at these massive populations, this very large population, and with very little help, meaning very little mental health professionals. Although we are seeing now more and more mental health professionals available, but still these are concentrated in the larger cities, in the metros and the tier one cities. Once you go to the tier two cities or below, the number of mental health professionals is close to minimal, and that definitely leads to a lack of good care. And we also find that then patients from tier 2 tier 3 cities are then seeking help from professionals in the tier 1 cities or in the metros, right? So which means that finally, at the end of the day, we have only so many mental health professionals and only so many man hours. And of course, that leads to either the costs escalating, or leads to a lack of care. So considering that, I think technology can be very helpful in terms of at least doing things that the mental health professional uh, may not meaning be able to do every time, in the sense that when we look at uh, we have a lot of apps these days. The problem, however, being that a lot of these apps are not necessarily standardized or doing following any protocols per se, which is also another issue, because there's There's no per se standardization, regularization of apps around the country or the world in general. So which leads to problems, yes, but I'm trying to say that these apps are also useful in terms of doing things that are repetitive for the practitioner, which would be repeated assessments to look at improvement in symptoms, looking at providing simple steps to deal with uh, anxiety, whether it's in terms of breathing exercises, relaxation exercises. There are also apps that work around uh, CBT, which is driven by AI, where the app itself will provide sort of steps to function when you, for example, if I tell the app that I'm feeling very anxious now, the app will ask me, what's making you anxious? Do you want to do a little 1 minute breathing exercises? I can offer that to you. So that's something that will be very useful. For example, at uh, 12 at midnight, if I'm feeling anxious, an app can support me. Doctor may not be able to support me, right? So I think these are things that can definitely where digital technology can add to making things easier and reduce the burden overall on the healthcare system in general. But yes, like I said, there is a need for a lot of standardization work and also looking at some regulations to be put in place, which is certainly lacking in many of these apps.
Thank you, Doctor. Doctor, are there any new molecules which have come up in the recent years which look at mood disorders?
Hmm. Okay. Somehow molecules, yes, there are newer molecules, but now more than molecules, there seems to be a lot of uh, push on devices. Now, I think whether it's driven by a bit of uh, profitability as well as by the need for something that is non-pharmacological, right? So there is a push for a lot of devices in place. So and these are things that have been around for a while. For example, uh, when we talk about repetitive transcranial magnetic stimulation, this has been around for the last 20 years or so, and is an effective treatment in terms of treating depression that is not responding to routine medication or treatment, in terms of treating OCD that's not responding to uh, routine treatments. Similarly, with, for example, severe depression, there are newer treatment modalities, which is ketamine, for example. Ketamine is fairly new in the sense that, again, it's around 10 to 15 years been around as an antidepressant per se. Ketamine has been used as an anesthetist agent for many, many years, but as an antidepressant, especially in acute cases with suicidal ideation, it has become a sort of replacement for not replacement, I would say, but it has become something that can be used instead of ECT, for example. ECT still is a very pertinent treatment in severe depression with suicidal ideation, but for patients who refuse ECT or who cannot be given ECT because of some contraindications, then ketamine is a good option in terms of uh, helping in terms of acute depression to quickly transition them into a better place so that other treatments can start working. So these are some of the, then we have also transcranial direct current stimulation, or TDCS, another modality that is coming into place. There's a lot of new, again, devices that are being marketed, again, without enough standardization, etc. There are devices for TDCS to be done at home. There are devices that work on what is called vagal nerve stimulation for depression and stress, again, being um, marketed pretty frequently these days. So there are a lot of these newer modalities that are coming into place, but I think they need a lot more assessment and sort of evaluation, and need to be used much more before we are able to say that they are effective.
No, thank you, doctor. Thank you very much. And the last question. So Saraswati and me and other people are a group of family carers.
Mm.
And I just wanted to put a quote from Abraham Lincoln, which says that I think the greatest burden we bear is often one unseen by others. So in our
Right,
groups,
very true.
basically the usual question by all the family carers is that just because you're looking after somebody and it's a long-term disease, so most of the people say that they are also suffering from either mood disorders or psychosis. So it is just said, it is put, but we don't know whether they are suffering or not. But there's
Mm.
definitely chronic stress. Uh, the first journey, like I and Saraswati were trying to put to people, is that there's a problem in the family. So I think that which is what we have realized, and we are dealing with it, but it is unseen by others. So what would be your advice to family carers in family and across many groups, that how they can actually take care of themselves? How do you take care of this chronic stress long term? And how do you communicate to other people that there is not quote unquote a burden, but there is a particular condition we are trying to manage long term?
I agree. Anay, I think what my work with bipolar disorder and bipolar India has taught me is this: having a support group of carers has, and what you're doing with families also, that having this support group does help immensely. I think it gives a lot of validation. It gives a lot of support. It also reminds you that you're not alone. It there are resources to support you in cases of crisis. So even if you can't access healthcare at that time, but the caregiver groups itself become very powerful resources of care and support. And I think that is something that needs to build and needs to be developed more strongly, because I think that is something that will go a long way in terms of uh, ensuring that the support is more continuous and is available to all of these individuals. And of course, and it is the support to the caregivers that is essential here, because the caregivers are going through a lot. There's no doubt about it, because they are struggling dealing with the patient. There's the financial burden, there's the treatment burden, there's the loss of time and occupation related to taking care of the person with mental illness. So all of that is definitely there. I don't think we should undermine that at all. But yes, creating that strong support system, creating that being there for each other, and that regular engagement in terms of asking questions, being able to find support, being able to solve smaller nitty-gritties, right? There are some very smaller issues that sometimes we have to deal with, including, for example, finding medication or knowing where to go for medication. There's some very uh, s- things that seem minor, but in the larger scheme of things can be very stressful and difficult. So there's all of that, and this strong support systems are going to be essential to care. And there's still not enough of strong support care groups in all over, right? And we're looking at groups primarily again in metros and in bigger cities, while we really don't have all that support in other places. So I think that's important to build on this and develop it into to reach to a wider audience. Um, and also, yes, caregivers, like I said, must find time for themselves, must take care of themselves, must ensure that they are functioning well in order to be able to support their family members. Because otherwise, unless they are managing themselves, it becomes very difficult to deal with this burden of care. And if they find that they're being overwhelmed, they're finding themselves to be more irritable, angry, upset, unhappy, they should also seek help. That certainly needs to be done when required, because very often family members will not seek help because they're like, now I'm adding to the burden of illness in the family. So there is absolutely no harm in seeking help, because unless you take care of yourself, you're not going to be able to help the other. And like the cliche goes that unless you the we talk about, unless you first wear your own mask, you can't be helping out the person next to you. So all of that is certainly important in terms of uh, taking good care of yourself, acquiring enough information. I think information is a huge uh, sort of treasure trove to help your patient as well as help yourself. And also creating support groups around you within your family, involving more than one person as the caregiver, not to take all the caregiving burden on an individual only. And like I said, on a larger scale, having these support groups and support systems outside the family as well, that are available to you in cases of crisis or difficulty.
Doctor, I wanted to ask you one question is, how
Sure.
can the family carer play a big role in understanding the person with mood disorders? I mean, I find a lot of families, uh, blaming always in that
Mm,
space, or,
mm,
victimizing the situation, being remaining in the past rather than,
mm,
know,
mm, mm.
I mean, I find that especially because when you're part of a lot of WhatsApp groups and you see continuous messages which are happening,
Correct, correct.
and I find this, I do understand what they're going through is not
Mm.
easy. But how do you think we can help these families? I mean, what
Right.
would be your message to these families?
Agreed. So one of the factors for this victimization is usually burnout, right? Feeling angry towards the person, feeling upset towards the person is usually a sign of burnout. So we need to evaluate whether there is burnout happening there. Besides that, like you were pointing out, what tends to happen is when there's such a long-term history of illness, and these are in decades that we are looking at, right? People who have been suffering for decades. Um, the who the person was before the illness is sometimes completely lost or forgotten. I think that is something that we is almost difficult to sort of go back to. I think that's something that we can always talk about, just about how was he before the illness started? What was he as a person? How did he respond to situations? So to be able to also say that this is the person and this is the illness, I think that is something that is very difficult to differentiate, but needs to be reinforced, that there is this person and there is an illness with this person, and the illness is sometimes overpowering who the person is. So I think that is something that we can need to bring up to them, bring out in them, and also sort of looking at what are his or her strengths, what are the things that he or she is good at, the person with illness. What was he doing before this? How was he managing things? So then to be able to again reinforce and remind the person that, see, there is this human being and there is this illness. And this illness is not the human being. So we need to be able to differentiate these two so that we don't be angry at the illness. We're not upset at the illness. We're not trying to sort of blame the illness for everything. Uh, the illness can, of course, cause a lot of difficulties, which impacts the caregiver, but also to check in whether the caregiver is burning out. So, is the caregiver feeling low, unhappy? Is he emotionally overburdened, not able to take care of him or herself? That's also something that we need to identify. And so, if we can provide some supports in terms of either through the group, through other peers who can be available to them to support them during these difficult times, or especially during a relapse kind of situation when symptoms have worsened and then the family member is overwhelmed again. So during that period, at least if some support can be provided uh, to the caregiver, it may help us tide over that situation little with a little more comfort. Like I said, although I talked about having more than one caregiver, but in many families, there may not be that luxury of having more than one caregiver at all. So, again, that if we can find someone who's part of the group, someone who understands the illness better, who knows how to deal with things, who can just be there as a support guide, I think it makes things a lot easier.
Yeah, thank you, Doctor. Thank you, Saraswati, for that question. Uh, so I think I would just need to say that there's one quote which says, "What would life if we had no courage to attempt anything?" This is for all our family carers and people who are living with mental disorders. I attempt even through darkness, hoping for less judgment and more understanding. So this is a quote by Vincent van Gogh, and I think that is what Saraswati was actually trying to ask, that family carers are actually struggling, and I think that's a very wonderful explanation from your side, which will actually help all our family carers and people who are trying to cope up and live with mental disorders. So thank you very much for your time from Saraswati, me, and the family group of family carers. Thank you, doctor, for your valuable time in your busy clinical schedule. And it was wonderful talking to you on this subject.
Thank you. Sim.
Thank you very much, Doctor.
Thank you.